Welcome again, and thank you, members of press, who are taking the time to listen to this briefing by the Pan American Health Organization on the current status of the influenza A H1N1 virus. To date, PAHO and WHO have mobilized 29 experts to travel and work in the field in Mexico with their Mexican colleagues to help the Ministry of Health control this outbreak. In addition, PAHO and WHO is mobilizing the necessary antivirals to be sent to our member countries. Many supplies have been already sent as we speak. In addition, PAHO has organized a team that is traveling to Central America and has arrived to support the 3 countries that have recently reported cases. This team will help those countries strengthen their efforts in surveillance, laboratory procedures, infection control, and the management of acute cases. We are helping Central America get the necessary lab supplies, personnel, protective equipment, and, as I mentioned earlier, the antiviral drugs. All this work has been a team effort and has been supported with help from our colleagues in Public Health Canada, the CDC, and WHO Geneva. For countries where the virus has yet to be reported, PAHO has provided detailed guidelines for healthcare facilities to follow up and get better prepared. These guidelines recommend, for example, activating hospital emergency committees, boosting infection control procedures, setting up triage areas adjacent to the hospital but not part of the hospital in order to deal with what will be a potential surge increase in the numbers of cases, and giving hospital workers the necessary training in the use of the protective gear required. These kinds of procedures are essential as the virus spreads to other countries. Recent reports in the published scientific literature are confirming some of our initial impressions about this outbreak. Findings suggest that the spread of the epidemic has been relatively rapid, more rapid than the regular seasonal influenza that we experience. We are also beginning to see more evidence of patients who are asymptomatic. That is, they are infected but do not have symptoms. They are asymptomatic. These findings also suggest that the H1N1 virus may be more contagious than the seasonal virus that we normally experience. Having said that, though, we do not want to diminish all the efforts and the importance in mitigating the seasonal influenza infections. Each year, seasonal influenza causes a substantial morbidity and mortality in the region. So southern countries about to enter their winter season need to complete their seasonal vaccination activities as soon as possible. We know that H1N1 virus tends to cause more severe infections in people who have existing underlying health conditions such as heart disease, asthma, renal disease, and a host of other chronic conditions. We also know that outside Mexico, nearly all the deaths reported have occurred in people with these kinds of underlying medical conditions. We need to be especially concerned for persons at risk for complications, such as pregnant women, and the people that I referred to with chronic underlying conditions. Our surveillance and monitoring need to identify as early as possible infections in these risk groups so that they can receive early treatment and effective care to minimize the complications. Overall, the complete story on the severity of this disease is yet to be determined, and it continues to evolve. We certainly know that it's not nearly as high as the 1918 pandemic, where globally 40 million people died. Some data suggest, though, that the severity of this particular outbreak may be comparable to other pandemics, such as the one that occurred in 1968. But we need to keep reminding ourselves that this is still too early to make definitive conclusions. We're experiencing a new virus, and because it's a new disease, we have no prior protective immunity. All this information supports our early calls for countries to the south to be adequately prepared and to start implementing their emergency response plans. PAHO and WHO are going to be releasing soon updated guidelines for the clinical management of patients with suspected Influenza A H1N1 infection. Perhaps most importantly, we continue to call upon individuals and their families to take the necessary precautions to diminish the risk of infection. Cover your cough and your sneezes with a disposable tissue. Wash your hands frequently. And if you are sick, stay home from work and school and postpone travel until you become well. Again, we are not sure how this situation is going to evolve, so let's remain focused on being prepared as possible. So with that, I'll entertain any questions. Thank you very much.
Okay, we have a number of questions from Illuminate. I will start with a question from Jesus Rivera Ayala from Radio A H1N1 in Honduras. He says, I'm going to read it first in Spanish and then give a quick translation in English. Como una de las organizaciones representantes de la humanidad, ¿por qué no se pregona para que otras empresas farmacéuticas de prestigio mundial produzcan los medicamentos que los países necesitan? He says, en el norte de mi país solo tenemos 15 cajas de Tamiflu y 50 cajas para el principal hospital estatal. He's saying, why doesn't the World Health Organization and PAHO help pharmaceutical companies produce more Tamiflu so that the countries that need it can have it? And he says that there are only 15 boxes of Tamiflu in one of the regional departments of health and 50 boxes for the main hospital in the main state hospital.
That's a great question. I can report that PAHO and WHO are doing everything they can with their partners to increase the global supply of antivirals and have already started work on producing a vaccine that will potentially have a great impact on the epidemic as well. The work going into the antiviral medications has to do with the stockpiles that exist with WHO as well as stockpiles that we have in Panama in our country office there. And we've dispatched as many of those supplies as rapidly as possible to the countries who need them most, including Honduras and Nicaragua of Central America. In any country, you're going to experience difficulties and challenges to getting these supplies out to particularly rural, isolated areas, and that will continue to be ongoing work that will need additional support as well. The total global supply is not sufficient to treat everyone if everybody got infected, but we are working hard. We are collecting as much information on demand that will help motivate and drive manufacturers to produce the necessary medications. There's other work where we can catalyze transfer technology, help newer producers produce generic supplies as well, and all that is being done.
Okay, thank you, Dr. Andrus. We have several questions from Patricia Marcano from Diario Último Noticias in Caracas. Her first question, I'll give them to you two at a time. One of them is, are countries obligated to report suspected cases or just probable and confirmed cases? And her second question is, in case that a pandemic is declared, does that mean that all the countries of the world will be affected, or is it possible that H1N1 will not arrive to some countries?
Both very good questions. The answer to the first one, countries should be reporting their confirmed cases. In some situations, countries are giving a broader picture by reporting their suspect, probable, and confirmed cases. But to the extent possible, we're asking for this broader picture, but they are obligated to report confirmed cases. In respect to the second question, it's likely for the virus to spread probably to most countries. I can't pin a number or percentage on that, but what we're seeing, for example, in the United States, where it started in Southern California, it's virtually, I would have to say today, almost in every state. So we're seeing the same situation in Mexico, and those are large states, in many cases larger than many of the countries of the world. So I expect that the virus will end up in every corner of the world. Can I say that 100% of the countries? It'd be hard for me to predict, but it's going to be a great majority of the countries.
Okay, thank you, Dr. Andrus. I'll read two more of her questions. She says, is it possible that there's an under-reporting of cases and therefore that there are more people infected than what we know? And the second one would be, how much Tamiflu should countries have in reserve as a minimum to be able to anticipate their needs?
With regards to the first question, we're learning that with the additional information that shows us that there are less severe cases, even asymptomatic cases, I'm sure we're under-reporting. It's very challenging, even in a situation like with an initiative to eradicate polio, to report 100% of all the cases. We get close to that goal, but it's very, very difficult. So when you have a disease like this particular one, which also shows asymptomatic cases, it will be very, very difficult to capture every case with the surveillance. But it is, having said that, important to monitor trends so you can see how the outbreak is evolving in your country. I don't think it's particularly important to be so hung up on trying to identify every case. So it's very important to monitor trends, and in addition to that, be more focused on monitoring what's going on in high-risk populations, as I mentioned in the presentation. We are concerned about the safety of women who are pregnant, who become infected with this disease, and we're also concerned about the safety of people with chronic diseases. And the sooner we can identify infections in these people, the better able we are to provide the necessary treatments. In terms of Tamiflu, there are targeted percentages for countries that we are working on to try to mobilize as an initial start to ensure that every country has a certain percentage of their population with supplies that would cover them. And that percentage, I don't know offhand, but it is our best estimate to provide adequate protection against the serious consequences. So that work is being done.
Okay, thank you, Dr. Andrus. Her last question is that she has seen a list of countries that have laboratory capacity to diagnose or to identify virus subtypes of the new H1N1. She says if a country is not on that list, what does that mean?
There has been an enormous amount of work over the last 4 years to develop adequate surveillance systems in every country of the Americas. And as I recall, beginning this work 4 years ago, I can't remember the exact percentages, but certainly no more than half of the countries had laboratories capable of using some of the sophisticated molecular techniques we now have available in diagnosing patients, such as PCR, the polymerase chain reaction. And so over time, the capacity for all countries to do this work has increased substantially. There's still room for improvement. There are still few countries that don't have the capacity, so we're working hard to get that capacity on board as we have delegated teams as we speak to go to countries to support with these activities.
Okay, thank you, Dr. Andrus. We'll take a question here from the room. We have Sylvia Yusuf of the German Press Agency. Sylvia?
Good morning. I was wondering if you could give us some more details about this team being sent to Central America and explain a bit more what are they going to do, and are these countries, three countries, affected better or worse prepared than the other ones of the region, or why are you sending them there? Thank you.
Those are very good questions. Generally, a rule of thumb, and I'll answer the second question first. A rule of thumb in public health practice is that when a country or a community reports an infectious disease, that reflects good work on the part of their surveillance system to identify conditions that would pose risks to the populations, like influenza. So it's actually very good work and does not reflect the fact that they're not monitoring. So imagine a situation where a country actually has a huge outbreak but does not identify it. So I think the fact that these countries have identified the presence of the virus, that it is circulating within their community, is excellent work, and that's the whole role of that's our whole job in working in the area of public health and surveillance of infectious diseases. This team is composed of epidemiologists and virologists. The focus for the virologists will be to go to the labs and ensure that these newer techniques, particularly for this particular virus, it has protocols to use the polymerase chain reaction to be sure that those procedures are followed, so we know that the tests are being used and will give us the most accurate results. The countries in South America and Central America have a great deal of variability in terms of their capacity, in terms of their resources. There's a great deal of diversity. And the countries I mentioned, like Nicaragua and Honduras, are some of our poorest countries, and so for that require additional resources, and that's the reason why we've sent those teams. But I'd like to repeat again how impressed I am that they have been able to identify these cases. And you asked, did I cover your questions? Yeah.
Well, it was basically that, and it's a big team, bigger than other countries.
And I don't know the numbers. I would say it would be guessing. I would think that as I recall from some of the conversations over the last couple of weeks, we were planning to send a team of 5 or 6 experts. I do know for today's report that 29 experts have gone to Mexico, a huge country with large population.
Okay, thank you, Dr. Andrus. We have a question from Amalia Altamirano Juan, editora de SEC de Internacionales. Not sure exactly what medio that is. Amalia wants to know how close are we to declaring a level 6 pandemic, and how long would a pandemic last?
Both very good questions. The level 6 declaration may or may not happen. We just can't predict that. If it were to happen, then certain criteria would need to be filled, and those criteria are having the conditions we have with a level 5, that is at least 2 countries in one region of the world having sustained community transmission of this virus, as we have seen in Mexico and the United States. Level 6 requires those conditions of level 5 plus at least one other country in another region of the world having sustained community transmission. We know from our daily discussions within a number of different groups of experts, 4 or 5 times a day, discussing the global situation. So we've learned a lot about what's going on in Europe, for example, And I know that global experts are keeping their eye focused on the patterns of transmission that are occurring there, particularly in Spain and the United Kingdom. The question comes up often, well, what is sustained community transmission? And there's sort of a way that's been helpful for me to understand this is that in particularly with in relation to this outbreak, the initial cases have been by far travel related. And when these individuals return home, in the case of students on holiday over spring break, return home to their school, they expose other students and other colleagues to the virus, and we see additional cases. But it's in a confined community like a school. We also see this in small villages, usually again related to a travel history. What makes something sustained is the fact that you don't have that very clear picture of the origin of the virus. We call this contact tracing, where you can trace the generations of the transmission of the virus. That's on one side of the coin. On the other side of the coin, you have a situation like we see with seasonal influenza, where I may come down with symptoms and I just don't know the source of the virus. I may be at home, I may be at work, but was I exposed to it 3 days ago when I took the bus home from work, or I just don't know where I got it. So in that situation, where there's less defined information about origin, we call that sustained community transmission. And that's what we're looking for in the other countries, perhaps in Europe. This may or may not happen.
Okay, thank you, Dr. Andrus. She had a couple of other questions. One is, why aren't there any cases in Honduras? It seems that everybody in Central America has cases except for Honduras and Nicaragua. She also wants to know, when will a vaccine be available and what country is producing it? And are antivirals still effective against this virus?
I'll start in reverse order. The last question, yes, the antiviral oseltamivir is sensitive and effective in treating this viral infection. There is another class of antivirals where we found resistance, so be sure you know which viral agent is being used. But by far, the one that PAHO and WHO is dispensing is the oseltamivir antiviral medication. The vaccine, the question about when will it be available, our best guess is 4 to 6 months, depending on the methodology being used to produce the vaccine. And there are a number of producers involved. WHO and the WHO collaborative centers are working around the clock to produce the candidate vaccine strains for manufacturers to use to produce the virus, and these strains will be released as soon as they have made them. We given all this information, estimate that the earliest would be 4 months and perhaps as late as 6 months. And I'd like to emphasize that this is by far a better situation than when we were looking at 3 to 4 years ago, when we were predicting if a pandemic were to occur, it would take 6 to 8 months. So a lot of progress, a lot of technological and technology has been developed to expedite the process as well.
Okay, and she wanted to know about cases in Honduras.
The question, having not been there myself recently, the question always gets back to, is surveillance being done? Is it being done adequately? Is it of sufficient quality? Where cases or an outbreak might be missed? Or is it just the fact that they have not had the importations yet that we expect most countries to receive? Having worked with our colleagues in Honduras and knowing what I know about their immunization program, I would lean more to the latter situation where they are doing everything they can to get prepared, because I know their childhood vaccine program is excellent with high levels of coverage, and they have good surveillance. So the question then becomes, does the surveillance does it also work with the influenza well? So that I don't know the exact answer, but those are the kinds of ways I would look at it, and I am pleased to announce that our teams are planning to cover Honduras as well.
Okay, thank you. Okay, this will be our last question. This is from Eugenia Bolaños from Fundación Corazón Azul. She says, yesterday, Professor Neil Ferguson said in an interview with the BBC that H1N1 could affect about 1/3 of the world's population, and it could kill 4 in every 1,000 infected people. If that's correct, we're talking about 9 million people that could die. Are these numbers correct?
Those are estimates, and this particular person, Dr. Ferguson, is an author on a paper that's being referred to in this particular question. The group of researchers who conducted this research took a look at the Mexican data. They took a look at a snapshot of data and then used it within a modeling methodology to project or estimate what would be potential possible scenarios. So I'm going into this detail because it should alert you to the fact that it's a prediction, not the reality. It's not, it's their best estimate given a methodology that requires certain assumptions. And it is a snapshot of data. That snapshot picture that we see may change tomorrow, may be different in a week or 2 weeks. That's an important, I'm going to review a couple of more points, but I want to make that clear. The other thing about this study is that it's not a controlled study, so the science behind it is less rigorous than if it were a controlled study where you can put more weight on the results and make more definite inferences. I do believe they are attempting to use the data available despite the fact that it may be there may be underreporting of cases. We don't know the denominator data. There have been changes in the case definition, a number of factors that might bias the analysis. It's their best attempt. So I think in public health we always try to do our best with what we have. That's another issue. But I think that to project those kinds of figures on the situation that we have today should be taken with a grain of caution, because, and not just a grain of caution, a great deal of caution, because we have a changing situation. We have much more capacity at the country level to deal with crises as such. I recall back in the early 1990s, I believe it was 1991, we had a cholera outbreak in the Western Hemisphere that has been labeled, by the way, by historians as the 7th pandemic of cholera in the history of the world. So it was a huge pandemic that killed thousands of people, infected millions of people, that spread across the Western Hemisphere and spread rapidly and virtually to every country. The response was admirable, but it's not like the response that I'm seeing today. And I can remember vividly working in Colombia, one of the first countries with the cholera infections, and how the minister happened to be a sanitary engineer. So he promoted hygiene that helped control the outbreak. But the response that I'm seeing from countries like Colombia and the rest in the region is far more rapid. It's more aggressive. I think we have better infrastructures to deal with cases. We are putting focus on those patients that have underlying medical conditions, those patients that are at risk. So there's a lot more that meets the eye that makes it difficult to make comparisons. So to say that X million will die globally, I have to take that with a lot of concern and think through what we have at hand and the potential of doing the basics that we've been communicating in every press conference, such as washing your hands very, very frequently.